Radiologist second neuroradiology session on exploring imaging features of leukodystrophies. In the first session, we have discussed about the imaging features of adrenoleukodystrophy, metachromatic leukodystrophy, and Krabbe's disease. Today, we will be discussing few other interesting cases of leukodystrophies that we see in our clinical practice. It is a pleasure and a privilege to introduce my teachers and the moderators of this session, Professor Atin Kumar sir and Professor Shefali ma'am. Sneha, can you please share the CV slide? Professor Atin Kumar sir is Professor of Radiology and also an expert pediatric neuroradiologist from All India Institute of Medical Sciences, New Delhi. He has authored several publications in national and international journals and also authored several book chapters. He has delivered more than 175 invited guest lectures in national and international conferences. Sir is a recipient of International Scholar 2014 of Society for Interventional Radiology, V.K. Lakhanpal Gold Medal of IRIA 2011, and Academic Excellence Award of Delhi, IRIA 2016. His areas of interest are pediatric neuroradiology, trauma radiology, and interventional radiology. The next moderator of this session is Professor Shefali Gulati ma'am, who doesn't need any introduction. She is the Chief and Professor of Pediatric Neurology Division in the Department of Pediatrics, AIIMS, New Delhi. She is the President-elect of Association of Child Neurology, India, 2023 to 2025. She is also the INSAR Global Senior Leader for India 2021 to 2023. She is also founder member of Association of Child Neurology in 2002 and chairperson of the Academy of Pediatric Neurology IAP 2021. She is also executive board member of IES 2021 and co-convener of Pediatric Epilepsy Subsection IES in 2020. Ma'am is also a recipient of a National Award for Outstanding Efforts in Science and Technology Communication in February 2021. She was also a recipient of Sheila Wallace Award by International Child Neurology Association in 2014, Fellowship Award by Faculty of Medicine, McGill University and ICNA 2010, and a Lifetime Achievement Award by National Neurology Chapter of IAP 2014, and Dr. I.C. Verma Excellence in Research Award in 2018. Ma'am has also her areas of interest are autism, epilepsy, neuromuscular disorders, cerebral palsy, neuromodulation, neurorehabilitation. She has authored several publications in national and international journals, including NEGM and JAMA Pediatrics. And she has delivered more than 500 invited talks in various national and international conferences. I would kindly request Shefali ma'am to introduce the presenters of this session. Over to Shefali ma'am.
Thank you, Sangeeta. Thank you, the organizers from AOCN Web Academy, the education vertical, for having our team over. Neuroradiology in Child Neurology Division Department of Pediatrics is synonymous with Dr. Atin Kumar with us and always there. So he's it's very nice, and to be always jointly presenting, because he's our pillar of strength and a backbone of neuroradiology for us. Dr. Puneet and Dr. Sakshi are two brilliant DM trainees, and they will be presenting some interesting cases which will be discussed from a neuroradiological point of view. Dr. Puneet, can you start sharing your screen, please?
Yes, ma'am. Yes, ma'am. Are the slides visible, ma'am?
Yes, they're full screen. Please go ahead.
Yes, okay. Thank you, ma'am. I'm Dr. Puneet. I'm a DM Pediatric Neurology resident at AIIMS New Delhi, and my colleague Dr. Sakshi Oza will be presenting 4 interesting cases of leukodystrophies. To begin with, this is the first case. She is a 6-year-old girl. She presented with global developmental delay. On examination, she had increased tone more in the lower limbs and bridge DTR. She had bulbous symptoms, and she required multiple admissions because of recurrent LRTI due to the respiration pneumonia. So if we see first the T2 axial sequences, we find that there is a diffuse affection of the white matter involving the anterior as well as the posterior aspect. The basal ganglia and the thalami complex appear to be spared. There is some involvement of the brainstem in the anterior part. If you look at the T1, the corresponding hyperintense areas now here appear with low signal intensity. atrophy. On the T2 sagittal section, we find that there is some cerebellar atrophy is there, and the corpus callosum doesn't appear to be involved. On the flare sequence, we see that the some of the areas in the deep white matter, they appear, they have intensity, hypointensity, and some areas which have the intermediate signal intensity. So the possibilities were metachromatic leukodystrophy, adenoleukodystrophy, but however, there is no corpus callosum involvement, and mitochondrial leukodystrophy was one of the possibility. The genetics was sent for this child, and it confirmed the vanishing white matter disease. There was a pathogenic mutation in the AIF2B gene. So now we will start with the vanishing white matter disease. So a brief clinical description of this disease. It is also known as the childhood ataxia with central nervous system hypomyelination. It is an autosomal recessive condition, and the responsible gene, as we saw in the previous slide, is EIF2B, and the most common gene variant is EIF2B5. So there are various variants of the vanishing white matter disease. The antenatal vanishing white matter disease is very rare. It presents antenatally with reduced fetal movements, oligohydramnios, and post-birth we find that these children are encephalopathic. They have hypotonia, contractures, and there are systemic features in form of cataracts, pancreatitis, organomegaly, and there is ovarian dysgenesis can be found. The infantile form, that is Cre-leukoencephalopathy, it presents between 3 to 6 months. These children also have hypotonia, they have seizures, regression, and this is a very fulminant course, and the death is usually around 2 years of age. The most common form, that is a classical vanishing white matter disease, which we see, it presents between 2 to 5 years. These children usually have normal development followed by progressive cognitive impairment with cerebellar and the pyramidal signs. And one of the important feature is that there is episodic deterioration. So after some stress-like episodes like a trivial febrile illness or a trivial head trauma, these children develop the regression. Then there is a juvenile variant. It is not very common. It presents between 5 to 15 years of age. They show generally slow progression, but that is not always the rule. They have spastic diplegia, ataxia, and progress, and generally the cognition is preserved. Typically they have a longer survival, but some of these juvenile cases can have a very fulminant and a very progressive course. Then there is the adult form, which presents with seizures. Psychiatric symptoms in the adult onset vanishing white matter disease are common, and also the motor manifestations might be there. So we see that there's a clinical symptoms and the disease severity are correlated with the age at the disease onset. Earlier is the onset, more severe is the disease. We will look at the vanishing white matter disease MRI features. So on the we find that there is an abnormal signal of almost all the white matter. So in this T2 section, we see that almost all the white matter appears to be hyperintense, but there is more involvement of the deep white matter. And important, one of the characteristic feature of vanishing white matter disease is there is the rarification and the cystic degeneration. So this rarification and cystic degeneration cannot be here better appreciated on the T2. But if we go to the axial flare sequence, we find that there are some areas which have signal intensity similar to the CSF, and some areas which have intermediate signal. So these areas represent the cystic degeneration where the white matter has disappeared, while the these areas with intermediate signal are representing rarification, the white matter which is under the process of degeneration. Then the important feature is there is a melting away of the white matter. So there will be progressive cystic degeneration, which starts from the center and then progresses outwards, and this leads to the melting away pattern of the vanishing white matter disease, and hence the name is derived from this pattern. Which we can better appreciate this on this MRI. This is a 2-year-old boy. Initially, this MRI shows that there are some signal abnormalities, and we do find some loss of the white matter, but 10 months later we find that the white matter has almost disappeared. What is important is that we find that there is a cystic fluid filled space between the ependymal lining and the cortex. So the white matter has not collapsed. That is another important feature of vanishing white matter disease, that we don't see the collapse of the white matter. There will not be contrast enhancement. Cerebellar white matter may be involved, but we will not find the rarification and the cystic changes in the cerebellar white matter, and the atrophy may be or may not be there. Other features are that there will be a radiating stripe-like pattern. So the white matter which is adjacent to the perivascular space will be relatively preserved, and we can appreciate it better on the sagittal section as well as on the axial also. And the sequences on which this can be seen is flare and also on the T1. So we will find this sunray kind of appearance of stripes. These represent the remaining tissue strands. Another important feature is corpus callosum involvement. So corpus callosum involvement may not always be be there in the vanishing white matter disease. But if it is there and we find that there is an inner rim of involvement of the corpus callosum is there, so this finding is not very sensitive, but if it is there, it is very highly suggestive of vanishing white matter disease. Now coming to the vanishing white matter disease features in the neonates and infants, so the MRI interpretation may be difficult in these children. What we find is that there will be a coarse gyral pattern, which we can see here. There will be swollen white matter, as we can see here in this image, that the subcortical as well as the deep white matter both are affected. The basal ganglia complex appears to be spared. And on the axial section, this is a child who is 3 months old. So we do find some areas of rarification in here. And at 6 months of age, we find that the signal intensity in the white matter has progressed. The intensity has increased. Also, there is more area of affection of the white matter. And we see here, as the arrow indicates, that there is no involvement of the globus pallidus also. And as we see the progressive scans, we will find there is more and more degeneration of the white matter, and eventually it leads to the complete loss of the white matter. Now, this is a 2-year-old girl. This is the MRI which was done at 2 years of age. So we find that there are symmetrical anterior as well as the posterior involvement of the white matter. At 2 years later, that is at 4 years of age, we find that the signal in the white matter has increased. Now there is a progressive involvement. It is now involving the subcortical white matter also in the anteriorly as well as in the posterior area. And at this age, in the axial section on axial flare section, we find that there is some areas of the cystic degeneration as well as some areas which are showing radification with the intermediate signal. 2 years down the line, that is at 6 years of age, we find that now there is a even more progressive white matter loss, and we find this typical strands on the axial section, thus reflecting the progressive white matter loss. Now coming to the vanishing white matter disease MRI criteria, these criteria were given by Vanderneff et al. In 2006. So there are 7 obligatory criteria and 3 suggestive criteria. We will go through them one by one. So the first criteria is there will be a diffuse white matter involvement. The subcortical white matter will be relatively spared. There will be rarification and the cystic destruction, as we saw in the previous cases. And if the white matter has significantly disappeared, we will find that there is a fluid-filled distance between the ependymal lining and the cortex. There will be disappearance, progressively disappearance of the cerebral white matter, that is the melting away pattern. Temporal lobes are relatively spared. So cystic degeneration as well as the rarification will be very late in the temporal lobes. And if we find such changes happening early in the temporal, then we should doubt our MRI possibility of vanishing white matter disease. Cerebral white matter, as I told previously, also may be abnormal, but we won't find the cystic changes in the cerebral white matter. There will not be any contrast enhancement. And then there are suggestive features like the radiating stripes, pontine tegmental involvement, and the inner rim of the corpus callosum. So the important thing to remember is that these are for the MRI based diagnosis in a typical MRI. This may not be suitable for early onset disease or in a infant or in the neonatal age, but even in these cases, we do find some of these characteristics mentioned here in these criteria. So now coming to this case, this is a 17-year-old boy. He initially had symptoms at 13 years of age, that is 4 years ago. He had falls and 1 episode of generalized tonic-clonic seizure for which the MRI was done. Now at 17 years, the child doesn't have any deficits. The examination is normal. He's cognitively normal. The school performance is good. And so we see the T2 axial sequences. We find that there is a symmetrical anterior as well as the posterior white matter involvement, which is predominantly involving the deep white matter. The basal ganglia and the thalami appear to be normal. On the flare sequence, we don't find any overt features of any cystic degeneration or any rarification. But if you look closely at this sagittal section, T2 sagittal section, we do find that there is the selective involvement of the inner rim of the corpus callosum, which is involving the body of the corpus callosum as well as the splenium. So based on this, the first differential of vanishing white matter disease was kept and the genetics was sent, and it did confirm our diagnosis. It showed the compound heterozygous mutation in the AIF2B1 gene, hence it was labeled as vanishing white matter disease. Now, building upon this only, in this paper by Vandernepp et al., they have included 7 cases of vanishing white matter disease, which were genetically confirmed. And all these 7 cases, they did not have any signs of rarification or cystic degeneration. And all these children, patients were less than 20 years of age. And in all the 7 of these patients, they found that the inner rim of the corpus callosum was affected. As in this case, this is the 15-year-old patient in whom we find that there is a more affection of the deep white matter. The same thing is visible on the sagittal section. On the sagittal flare section, we find that there is a selective involvement of the inner rim of the corpus callosum. 4 years down the line, we see that at the 19 years of age, this child does show the cystic changes which have now appeared. So it is very important that we look at the corpus callosum changes in vanishing white matter disease. If at all it is present and it is involving the inner rim of the corpus callosum, it is very highly suggestive of vanishing white matter disease. So just to revise the corpus callosum involvement pattern, all the layers will be involved in the metachromatic leukodystrophy, Krabbe's disease, and the adenoleukodystrophy. Inner rim selective involvement, as we just now discussed in vanishing white matter disease, and the central blade of the corpus callosum will be involved in the mitochondrial leukodystrophies. So coming to the restriction, diffusion, and its role in the vanishing white matter disease. So in this paper, they have looked at the 46 MRI images of the children genetically confirmed with vanishing white matter disease. And they found that 32 out of the 46 children, they showed diffusion restriction. And these children typically were young and they had shorter disease course. Common areas showing this diffusion restriction was subcortical white matter, cerebellar white matter, plaque, and the splenium of the corpus callosum. And the diffusion restriction was seen in the tissue which has yet not completely cavitated and it is under the process of cavitation. So we can see here that on the T2 sequence, we find that there is a diffuse white matter involvement. And here we see that the areas which have undergone cystic degeneration already are labeled with the yellow arrow, which are not showing any diffusion restriction, but the area which is still undergoing cavitation or rarification, it is showing some diffusion restriction on the diffusion restriction in the DWI images. And in this another case report of a 22-month-old child, they have demonstrated that there is a cranial nerve root enhancement. And also in this child, there was a spinal root enhancement. So these can be some of the findings which can be found in the vanishing white matter disease. Now, coming to the radiological differentials, Krabbe's and Canavan's are one of the radiological differentials, extensive because they have extensive or diffuse cerebral white matter changes, but as a rule, we won't find any cystic degeneration in these Krabbe's and Canavan disease MRIs. In the Alexander, there will be frontal predominant and the contrast enhancement will be seen, which is not seen in the vanishing white matter disease. And in the megalencephalic leukoencephalopathy with subcortical cyst, we will find the cyst occurring first in the temporal area, and there will be diffusely abnormal and swollen white matter, especially in the younger children. In the mitochondrial leukodystrophies, the deep gray matter and the brain stem abnormalities will be very prominent. So coming to this case, this is the 3-year-old girl who she had a global developmental delay, and at 2.5 years there was further regression of the milestones. So on this flare axial sequence, we find that there is a symmetrical deep white matter hyperintensity is there, and on this we find that there is some cystic changes and some rarification of the white matter is happening. And when we see the sagittal section, we find that there is a selective sparing of the inner as well as the outer rim and the selective involvement of the middle blade of the corpus callosum. So genetics was sent for this child, and it did show a mutation in one of the mitochondrial genes. Hence, this was a mitochondrial leukodystrophy, closely mimicking the vanishing white matter disease. This is a very highly and unpredictable course in adolescent and adults, but early, as we saw earlier is the onset, more fulminant is the course. So the motor problems are the most common in the children, but while in adolescent and adults, they are more likely to exhibit cognitive problems. The favorable outcome features are seizures and onset more than 4 years of age, and unfavorable outcomes are stress-provoked episodes and onset less than 4 years. So the management is basically conservative management, supportive management, rehabilitation, aggressive treatment of the infections, antipyretics for fever, and to avoidance of any stress factors. No definite treatment as yet for vanishing white matter disease, and the only prevention is the prenatal diagnosis. So now moving on to the next leukodystrophy. This is a 4-year-old this is the fourth case. This is the 8-month-old boy who had global regression and seizures after 6 months of age. On examination, there was central hypotonia and macrocephaly was there. So on the T2 sequence, we find that there is a diffuse white matter involvement. It is involving the subcortical as well as the deep white matter. We do find the hyperintensity involving the thalami, and also there is a very significant hyperintensity in the bilateral globus pallidus. In the infratentorial region, we find that there is a brainstem hyperintensity is seen in the involving the dorsal aspect. On the sagittal section, we see that there is an involvement of the brainstem, which is extending from the midbrain till the medulla, and there is an involvement of the white matter of the cerebellum. So keeping these pictures, and then the MRS is showing the NA peak at the 2 ppm. This confirmed the possible diagnosis of Canavan's disease. A brief description about the Canavan's disease. It is an autosomal recessive spongiform leukodystrophy. The mutation is in ASPA gene, which leads to the accumulation of the N-acetyl aspartate. The onset is at around 3 months of age. The children generally have lethargy, poor head control, hypotonia, poor feeding, and there will be visual inattention, followed by at around between 3 to 6 months of age, they develop macrocephaly. There will be hypotonia, which progresses to spasticity, hyperreflexia. Seizures are common, which will be seen in 1/3 of the patients, and death may occur in childhood, although survival into the teenagers is common because of the improved supportive care. So the non-infantile variants is controversial in the Canavan's disease, and now it is accepted that it is not a distinct juvenile form, rather it is a mild form which has started into the infantile age, and because of the slow progression, the clinical symptoms occur in the juvenile phase. And these children, they don't have macrocephaly who present in the juvenile age. So the milder disease is associated with specific ASPA gene mutations that produce benign phenotypes. So coming to the MRI features of Canavan's disease, so there is a diffuse symmetric involvement of the cerebral white matter, which predominantly involves the subcortical matter, and there will be progression from subcortical to the deep white matter in the from outside to inside involvement. There will be relative sparing of the deep white matter initially, and then in this child at 4 months, there is some sparing of the deep white matter, but at 8 months later, at 12 months of age, we find that there is no involvement of the subcortical as well as the deep white matter. So diffuse atrophy progressively sets in, and the brainstem tract involvement is a rule in the Canavan's disease. GP and thalami are involved, and the chordate and putamen are generally spared. Corpus callosum is relatively spared, and the MR spectroscopy, we find the characteristic NAA peak at 2.02, and there is no contrast enhancement in the Canavan's disease. This is a case published from our institution. So this is a 5-year-old boy who had insidious onset, mild motor and speech delay. There was a there was head circumference was between 0 to 1 standard deviation. Central hypotonia was there, and the brisk DTRs were present. So in this child, we see that there is no white matter involvement is there. We find the involvement of the bilateral involvement of the chordate and the putamen. The globus pallidus seems normal. The MRI shows that there is a high peak at the NA peak, which confirmed the diagnosis of Canavan's disease, and later on genetics also showed the pathogenic mutation. So this is an atypical presentation of Canavan's disease, that the globus pallidus is spared, and we find that there is no white matter involvement. Even the subcortical as well as the deep white matter appears to be spared. So now the role of the diffusion DWI images in the Canavan's disease. So in this 10-week-old male, there was nystagmus, central hypotonia, and the coriform limb movements. On the flare sequences, we find that there is some involvement of some hyperintensity we can see in the deep white matter. And on the T1 sequences, this area appears to be having a low signal. On the MRS, there was NAA peak, and the areas which are appearing hyperintense on the flare, they are showing diffusion restriction. So they have proposed that cytotoxic edema with diffusion restriction is common in infantile onset Canavan's disease. And if an infant presents with diffusion restriction, Canavan disease possibility should be considered as one of the differential. So now coming to the radiological differentials of Canavan's disease. So Alexander disease has macrocephaly similar to the Canavan's disease, but there is a marked frontal predominance and the caudate and putamen are involved. In the MLC, megalencephalic leukoencephalopathy, there will be macrocephaly, cysts will be there, and the sparing of the brainstem will be seen. And in the late onset MSUD, there will be the similar to the Canavan's disease, there will be globus pallidus and thalamus signal changes will be there. Similar to the Canavan's disease, we will also find cerebral, and the brainstem involvement. So it's the MRI of a late onset MSUD, like in this 4-month-old child, we find that there is a diffuse white matter involvement, which is involving the subcortical as well as the deep white matter. So in such a case, it is the lab parameters which can help us in differentiating between the MSUD, late onset MSUD and the Canavan's disease, and the MRI may be exactly same in both these disorders. It is most individuals with Canavan's disease, they die in the first decade of life, but with improved care, they might survive beyond the first decade. Treatment is predominantly supportive care. There is no approved treatment as if now yet. This is a clinical trial which is going on in the for the Canavan's disease, and the enrollment has started in 2021. So this trial is can aspire, and this is adenovirus associated gene therapy. The about 18 patients will be enrolled in this trial. It is a non-randomized allocation, and it is open label trial with up to children up to 30 months. Exclusion criteria is positive AVV9 titers, decerebrate or decorticate post-shrink, or the recurrent or refractory seizures. And the outcomes will be measured based on the urinary NAA change based on the baseline at 12 months post-treatment and on the MRS NAA peak. So this is a one-time gene therapy for Canavan's disease. This is the ongoing trial. So now I have completed my part of 2 leukodystrophies, that is vanishing white matter disease and Canavan's. The next 2 leukodystrophies will be presented by my colleague, Dr. Sakshi. Over to Dr. Sakshi.
Thank you, Dr. Puneet. Good evening, everyone. So moving towards the next leukodystrophy. So here we have a 7-month-old infant who presented to us with global developmental delay and a history of multifocal seizures for last 1 month. On examination, the child had central hypotonia, striatal toe, focal hand dystonias, and the head circumference was 48 centimeters, suggestive of macrocephaly. We ordered an MRI brain for this kid, and these were the images. So the first figure is the axial T1 weighted MRI brain section at the levels of basal ganglia and lateral ventricle. The second is a T2 weighted image, and the third is the T1 contrast image. So in the first image, the yellow arrows are showing towards the front bilaterally symmetrical frontal cerebral white matter signal changes in the form of T1 hypointensities. And here in T2, we can see this yellow arrow showing the T2 hyperintensities. The second striking features which we can see, this red arrow indicating towards a periventricular hyperintensity seen on T1. And here in T2, we can see the similar corresponding area showing hypointensities. The third thing which we can see here depicted by this blue arrow is some signal changes in the bilateral basal ganglia level. On given contrast, we can see patchy contrast enhancement at the frontal cerebral white matter near the frontal horn of lateral ventricle and also at the level of basal ganglia. So what can be our differentials? So first differential would be Alexander disease. Second can be a frontal variant of XALD, considering the frontal predominant cerebral white matter involvement. And the third, mitochondrial cytopathy, as we can see contrast enhancement here. But clubbing both the clinical features suggestive of macrocephaly and the typical neuroimaging findings, we kept the possibility of Alexander disease as high. So Alexander is a primary demyelinating leukodystrophy, which is a kind of astrocytopathy. Most of the cases are sporadic in nature, but familial cases, whenever occurs, the inheritance is autosomal dominant. The mutations are seen in the GFAP gene, which is a gain of function of mutation, which leads to the decreased solubility of GFAP protein. And this decreased solubility creates rosenthal fibers, which gets accumulated inside the astrocytes, and finally destruction of normal myelin. So we have 4 types of phenotypes of Alexander disease. The first is the neonatal form. So within the 30 days of birth, the child may be hypotonic, and there can be features of hyperexcitability in the form of myoclonus, along with some gastrointestinal manifestations in the form of GER or vomiting. This will further lead to global developmental delay, presence of refractory seizures, megalencephaly, and the death usually happens within 2 years. In the infantile onset, which is also known as the type 1 Alexander disease, the developmental milestones are usually variable. They can present as delayed development, or the plateauing of the milestones, or the regression of the milestones achieved. The child will be macrocephalic. There will be refractory seizures. Pyramidal as well as both extrapyramidal signs can be present, bulbar involvement, and sometimes hydrocephalus. Considering the blockage of CSF outflow because of the Rosenthal fibers, hydrocephalus can at times set in. In the juvenile phenotype, the onset is usually beyond 4 years of age, and it is also known as the type 2 Alexander disease, and the manifestations are usually milder than the infantile form. Adult Alexander presents as progressive bulbar or pseudobulbar symptoms, progressive gait abnormalities, cerebellar signs, autonomic dysfunctions, sleep disturbances, and the course is either relapsing remitting or slowly progressive. So in 2001, Vanderknapp et al. Framed a criteria for MRI-based diagnosis of Alexander disease. They retrospectively analyzed the MR imaging findings of 217 patients who were labeled as leukoencephalopathy of unknown origin. Based upon this criteria, 4 out of the 5 below points should be met for a MR imaging based diagnosis. So the first criteria is extensive symmetrical cerebral white matter changes with frontal predominance, as we can see here. The red arrows are pointing towards the bilaterally symmetrical white matter changes with frontal predominance. The second criteria is periventricular rim with hyperintensity on T1 and hypointensities on T2. As we can see in this picture, the red arrows in T1, the periventricular area is hyperintense, and the corresponding area in T2 is hypointense. The third is the abnormalities of basal ganglia and thalamus, which may include any of the following. Either there can be a swelling or increased signal intensity, or there can be a atrophy or decreased signal intensity on T2 weighted images. As we can see here, abnormal signal intensities involving the basal ganglia bilaterally symmetrically. The fourth can be the involvement of brainstem, which is usually seen either in the midbrain or the medulla, and mostly the periaqueductal part is involved with sparing of red nuclei. The fifth criteria is the contrast enhancement seen in the above areas, any of the one of these areas. As we can see here, there is a periventricular rim enhancement in this T1 contrast image. One more important sign which is commonly seen in Alexander disease is a frontal cap sign. As you can see here in the T2 weighted image, there is a ring-like lesion at the near the frontal horn of the lateral ventricle, which is hypointense on T2, and here this is appearing hyperintense on T1. So this particular sign is commonly known as the frontal cap sign. So in 2005, Vanderknapp et al. Found that in 10 patients who were genetically confirmed with GFAP mutation, the MRI findings were not strictly matching to the criteria which was framed in 2001. So they added some other abnormalities which can be seen in Alexander disease. The first is a ventricular garlands, that is a garland-like abnormalities along the ventricular wall. Or there can be exclusively involvement of brainstem, cerebellum, and spinal cord. Sometimes some space occupying lesions which resembles as brainstem gliomas can also come out to be Alexander disease. Brainstem and upper spinal cord atrophy can be present. Cystic formation in the frontal anterior horn, near the anterior horn of lateral ventricles, and cerebellar white matter signal changes with dentate nucleus hyperintensity can also be seen. So it was concluded that when MR findings do not meet the strict criteria for Alexander disease but are suggestive, DNA diagnosis is warranted here. So this case is of a 6-year-old boy who had a symptom onset in infancy, presented at 6 years to us with global developmental delay, macrocephaly, and seizures. So apart from the findings we discussed in the previous slide, we can see two other findings in the form of the nodular hyperintensity seen in brainstem here in the medulla, and this hypointense periventricular rim, which is known as the ventricular garland. So based upon the age of presentation, MRI features can be further classified. So it is seen that in neonatal and infantile form, mostly the periventricular rim or the basal ganglia and thalamus involvement is more than in comparison to the juvenile or adult presentation. Whereas in juvenile and adult form, frequently the posterior fossa structures are more involved, and they may typically, sometimes they may lack the typical MRI abnormalities. So the differentials for Alexander can be, if a child is macrocephaly, we usually think of these 4 differentials, but as we know, as we have just studied, that Canavan usually present with diffuse white matter changes, and there is globus pallidus involvement and mostly sparing of caudate and putamen. In MLC also there is diffuse white matter involvement, and the central structures are mostly spared. In glutaric acidemia type 1, it may typically resemble macrocephaly with with basal ganglia involvement, but contrast enhancement is not a feature of glutaric acidemia. In L2-hydroxyglutaric aciduria, again, the child can be macrocephalic, but here the subcortical and basal ganglia are involved with sparing of brainstem, which is commonly seen in Alexander variant. So for contrast enhancement, apart from Alexander, we have two other differentials, that is adrenoleukodystrophy and mitochondrial cytopathy. But in ALD, the primary involvement starts from the deep white matter rather than subcortical white matter. If we consider the frontal predominant white matter changes, the differentials can be frontal variant of XALD or late onset metachromatic leukodystrophy or L2-hydroxyglutaric aciduria. So diagnosis is basically made by clinical presentation as well as combining it with the neuroimaging findings, and a heterozygous pathogenic variant found in GFAP gene, which is identified by molecular genetic testing. Majority of the cases can be caught on sequence analysis, but there is one case report in which a deletion of exon 5 was reported. Earlier, before this era of genetic testing, the diagnosis was basically made upon the demonstration of Rosenthal fibers on brain biopsy or autopsy, and management is mostly supportive and multidisciplinary. So this is a 2017 published report where it was a preclinical trial was done where the use of antisense oligonucleotides, which were designed against the GFAP protein, was done, and these were intraventricular injections were given to both wild as well as the mutant mice, and they found that near complete and long-lasting elimination of GFAP occurred in brain as well as the spinal cord, with a striking reversal of Rosenthal fibers, giving us some hope for some future studies coming with good treatment in cases of Alexander diseases. Coming to the next case, here is an 11-month-old male child who came to us with some mild motor developmental delay. The child had a trivial fall from bed, which followed by excessive unconsolable crying, and a MRI brain was done by on outside basis. And on examination, the child had macrocephaly. So these were the MR imaging of this particular kit. The first image is a T1 axial MRI sections. Second is a flare section, and the third is a T2 axial section. Here we can see diffuse cerebral white matter involvement in the form of diffuse hypointensities seen on T1. Corresponding areas are showing diffuse hyperintensity on T2 weighted images, with some local hypointensity seen at the bilaterally anterior temporal pole in the frontal horn, in the frontal lobe, as well as here this red arrow is depicting some hyperintensity on T2 in the parietal lobe also. When a flare sequence was seen for this particular child, you can see complete suppression of these hypointensities, almost similar to the CSF intensities, suggesting cystic changes. So megalencephalic leukoencephalopathy with subcortical cyst, commonly known as Van den App disease, or vacuolating leukoencephalopathy or infantile leukoencephalopathy with megalencephaly. So it is a autosomal, the inheritance can be autosomal recessive or dominant, and three major phenotypes have been identified. Type 1, that is the MLC1, is contributes to the majority of the cases, that is around 70 to 75% cases, and occurs because of the MLC1 gene mutation. MLC2A and 2B are because of the HIPACAM gene mutation, whereas 2A is a biallelic variant and 2B is a autosomal dominant phenotype. They usually leads to the formation of glial cam protein. MLC2B is also commonly known as the improving phenotype, in which the course is usually static and usually improves both clinically as well as radiologically over the period of time. Founder effect is seen in Agrawal community, as we all know. The pathophysiology here also lies in astrocytes. Abnormal MLC protein or glial cam protein leads to dysregulation of iron and water homeostasis, and it finally leads to intramyelinic edema or swelling. So the presentation can be macrocephaly, which can be present at birth also, and usually it increases till 1 year of age, and the head size can reach up to 4 to 6 standard deviation. And it is seen that all patients with MLC, almost all patients with MLC have macrocephaly. Apart from macrocephaly, there can be mild motor and cognitive delay. Epilepsy is usually there, but mostly it is controllable with anti-seizure medication. Unlike, apart from that, we saw in Alexander disease. There can be temporary exacerbation with mild head trauma. In later ages, the child may have cognitive deterioration and ataxia, dysarthria, or the child becomes wheelchair bound by teenage, but many can even survive up to 40 to 50s. So the typical of MLC is the MR abnormalities are far more than the clinical features. So MRI brain in MLC, the first feature is a diffuse cerebral white matter swelling. In initial ages, because of this white matter edema, even a compression of the ventricles can be seen in early infancy. Whereas as the age progresses, the white matter signal changes, partly normalizes with age, and at the end, the cerebral atrophy sets in. Second is the formation of subcortical cyst, which usually starts forming from the anterior temporal region, which can even present as rarefaction in infancy, but it can also appear in frontal or parietal regions. With time, the subcortical cyst increases in size, and it is mostly due to increase in cerebral atrophy. Another feature which can be seen in MLC is enlarged cavum septum pellucidum. Mild abnormal white matter changes can also be seen in brainstem and cerebellum, but as a rule, no swelling will be seen in these areas. These are the external capsules which are involved predominantly. Posterior limb of internal capsule, if at all is involved, is usually present in the form of, we can see here in figure 2, the entire length of plic is showing hyperintensity. So either a double line of altered signal intensity you can see, or only the distal part of plic can be involved. Diffusion restriction is seen in almost all the above areas, and spared areas will be ALIC, plic, corpus callosum, periventricular rim of occipital white matter, cortical gray matter, and basal ganglia. These structures are usually spared in MLC. So the common differential again for macrocephaly, it can be Canavin, Alexander, L2-hydroxyglutaric aciduria, or GM1 or GM2 gangliosidosis, but they mostly present as hypomyelinating leukodystrophy. Another important differential is Merosin deficient CMD. Almost similar type of MRI features can be present in Merosin deficient CMD, and sometimes they can even present with formation of subcortical cyst. But in that case, the only way to differentiate is the absence of macrocephaly and the signs of muscular dystrophy. Cystic leukoencephalopathy in the form of Aicardi-Goutry syndrome, congenital CMV, both of them can also present with bilaterally symmetrical anterior temporal lobe cysts, but in these cases, calcifications usually sets in. Alexander is also a cystic leukoencephalopathy. RNase T2 deficiency. Here, the head size is usually normal. Coats plus syndrome or mitochondrial cytopathies. As far as diffuse cerebral white matter involvement is seen, we have already just now we have gone through the vanishing white matter diseases. Apart from that, paroxysmal disorders and almost all end stages of leukodystrophies will present as diffuse cerebral white matter involvement. So for diagnosis of MLC, molecular genetic testing, which is used, is sequence analysis. But in around 3% of the cases in MLC1 gene, deletion duplication has also been reported. Treatment is mainly supportive and multidisciplinary, but in this 2020 preclinical trial, adeno-associated virus was used, and it was the MLC1 gene was injected in the cerebellar subarachnoid space of in murine models, and they found that myelin vacuolation was extremely reduced in these treated mice at all ages. So it was it has shown better effects in both preventive as well as a therapeutic role. So again, giving us some hope for some future clinical trials. So this article was published in 2016, and this is the spectrum of leukodystrophies, which was retrospectively studied at our center. And we also found that out of 80, around 21 children presented with leukodystrophy were MLC. The age of onset of symptoms who presented to us ranged from early infancy to 11 years, and the median age was around 4 years. Ethnic community involved were mostly Agrawal, followed by Khandelwal community. We found none of the children had any significant family history, and out of the 12 children, 11 were attending appropriate classes. Bilateral temporal subcortical cysts were seen in almost all of the children, and all children showed homozygous mutation in MLC1 gene. With this, we'll end our presentation. Thank you.
So you're muted, sir.
Sorry. Thank you, Dr. Puneet and Dr. Sakshi, for an extensive detailed discussion about the 4 leukodystrophies which we discussed today. I think most of the points have been extensively covered, but yes, maybe I can just do a quick recap about the differentials which you need to consider again. So can I just show my screen, share my screen? Puneet, can you stop your screen?
Yes, sir.
Okay, so we all know this was discussed, I think, in the last webinar also on the leukodystrophy part 1. The current classification of leukodystrophies is based on this pathology-based myelin disorders, astrocytopathies, leukoexonopathies, microgliopathies, and leukovasculopathies. And the disorders which we discussed today are actually mainly predominantly from the astrocytopathies, the Alexander disease, the MLC, and the vanishing white matter, whereas Canavan's was in the category of myelin vacuolization, along with the mitochondrial and other disorders. The MLD and Krabbe's were discussed last time, right? So we're discussing astrocytopathies. A point to note here was, okay, let me go to the next slide. So this was a radiological based approach, which was earlier advertised, and we still follow this actually for a radiological based approach, because that's the earlier one was a pathology based approach. So in terms of the frontal predominance, which we saw today, we saw a case of Alexander disease. The other differentials for a frontal predominant is a frontal variant of X-linked adrenoleukodystrophy. Metachromatic leukodystrophy, they say they usually starts frontal, but most of the patients which I have seen in my experience are usually not having any significant predominance from frontal to occipital. It's more of a periventricular leukodystrophy, which we see. So a periventricular predominance is the characteristic metachromatic leukodystrophy. And we also saw a case of vanishing white matter, which could either be a diffuse cerebral or a periventricular predominance. Most of our cases, when we start seeing them initially, like a case which Puneet showed, which we followed it up over a period of from the age 2 to age 6, it started with a periventricular leukodystrophy type of a pattern, and then subsequently as the age progressed, it started involving the rest of the white matter, extending to the subcortical white matter with the melting away of the white matter. So that's periventricular to start with, and going on to diffuse, which is your vanishing white matter. MLC, as described today, is predominantly a diffuse cerebral, and the other differential for a diffuse cerebral actually is a Canavan's leukodystrophy. These are both leukodystrophies which we typically see as kind of extensively involving the entire brain parenchyma with what looks like almost a swollen appearance, usually for most of the patients which we see. And the points to differentiate between, and especially both of them actually present with macrocephaly. So Canavan's as well as MLC presents with macrocephaly. But the point to differentiate, as was highlighted by him earlier, is the pattern of involvement. The Canavan's will have a typical basal ganglia involvement, whereas MLC will have specific involvement of the temporal and the frontal lobes, in which you will have formation of cysts. That's how you differentiate the diffuse white matter abnormality with macrocephaly between Canavan's and MLC on a radiological pattern. Coming to, okay, sorry. So what I was also talking about was this specific basal ganglia pattern of involvement in Canavan's. When you see a specific involvement of globus pallidus and thalamus, besides the diffuse white matter abnormality, this is highly specific for Canavan's. And we can make a diagnosis of Canavan's in such patients radiologically, especially if we know there is macrocephaly, without any other differential based on this. In fact, Vanderknapp has said in her article that the involvement of globus pallidus and thalami with sparing of caudate and putamen is very specific for Canavan's, with only one differential in this, which is MSUD, as was elaborated by Puneet in his talk. So only differential to this pattern in which the caudate and the putamen are spared, but the globus pallidus and thalami are involved with some white matter abnormality is MSUD. And as was asked by one of our panelists again in the question answer, it gets difficult for us to differentiate between these two entities. The only thing is Canavan's will have diffuse involvement even of the frontal white matter, parieto-occipital white matter, besides the same pattern of involvement, whereas MSUD will typically have more of a posterior involvement. We all know the early myelinated structures are involved right from the brainstem to the subthalamic region to the thalamus and the GP. It's not so much of a anterior white matter involvement in MSUD at that time. And if there is doubt, we can still go ahead and do IMR spectroscopy. We all know NA is almost one of the exceptional leukodystrophies in which the NA is significantly elevated, right? And that's because of the underlying enzyme abnormality. When you have accumulation of N-acetyl aspartate, that's what leads to the same thing being seen on spectroscopy as elevated NA, whereas most of the other abnormalities will have decreased NA because of the neuronal loss. So that's what I wanted to highlight. But keeping still this in mind, we still need to know there are some exceptions to this rule also. So in especially the juvenile form of Canavan's disease or a later form, you can have a reverse pattern in which the caudate and the putamen are involved, but the GP is relatively spared. So this is an exception to the normal teaching rule. And this, we just need to remember this. This was a case which we saw, and I have seen another case also. This is only in the milder variants, the juvenile variants, whereas we know the infantile form of the Canavan's or the early form is a much more severe disease in which there is extensive white matter involvement. If you say this pattern, it's usually with a much lesser white matter involvement and much lesser course, a much milder course, and that you need to remember as an exception. Otherwise, in 95-99% of the cases of Canavan's, you will have sparing of this, where is involvement of GP and thalamus. Okay, this we have more or less covered. So macrocephaly was again Canavan's, MLC, and even L2-hydroxyglutaric aciduria, but Canavan's and MLC we've discussed pretty fine. Contrast enhancement, we saw a case of Alexander disease today, which has contrast enhancement, and the last time we saw a case of X-linked ALD. So basically, there are predominantly only three main leukodystrophies, types of leukodystrophies, which show contrast enhancement. We need to remember this because we don't want to give contrast in all the cases. We want to give contrast only when we are suspecting the specific indications. So one is X-linked ALD, in which the contrast enhancement is at the peripheral margins. Today we saw a case of Alexander disease when the contrast enhancement was typically at the tips of the frontal horns, in the frontal white matter, or along the Garland sign along the periventricular margins, or in the basal ganglia. These are the areas of contrast enhancement in Alexander disease. And the last one is mitochondrial cytopathy, which has a predominant white matter involvement, and there may be a patchy white matter or gray matter enhancement in mitochondrial cytopathies also. There may be other areas which can be involved in leukodystrophies, like optic nerve enhancement, or maybe spinal nerve root enhancement in MLD, optic nerves enlargement, and some enhancement in Krabbe's, but that's not in the white matter. So enhancement in the white matter is only limited to these 3 leukodystrophies, which we need to remember. I think we're more or less covered everything. One more point I wanted to highlight, which I think Dr. Sangeeta has just written in the chat also. In my experience, for almost all the patients of Alexander's disease, which I have seen, I think almost all except maybe one, and I've seen around 10 to 15 patients, we do see have a very strong association of cavum, septum, pellucidum associated with this in the patient of Alexander disease. So if you're seeing a frontal predominant white matter looking like a leukodystrophy, and you see associated cavum, septum, pellucidum, you can very strongly have increased confidence that you're looking for a Alexander disease. Obviously, like to give in contrast, look at the basal ganglia abnormality to make yourself feel more comfortable. And the other point, which already has been highlighted, I wanted to highlight in the differential between a just a pure periventricular leukodystrophy. If you see that and you want to think more in terms of a MLD, that's the most common which we typically see, vis-a-vis a vanishing white matter disease. Sometimes vanishing white matter may not show the rarefaction of white matter in the initial stages. As we have shown you 2 cases today, the rarefaction starts over a period of time. But if you just have a periventricular white matter predominant leukodystrophy, you have a differential of MLD or a VWM. Always look at the corpus callosum. The corpus callosum is one of the earliest structures to involve in a MLD. However, milder maybe changes in the white matter, the corpus callosum is involved. Maybe the splenium may be the part of the body, but it is involved even if it is a subtle involvement. And in my experience, I've seen it involved in each and every case of MLD. Actually, that's how significant it is. Whereas in VWM, the corpus callosum is typically spared most of the cases. If it gets involved, it's the inner rim of the corpus callosum only, which is shown, not the entire part of the corpus callosum. So it's a craniocaudal gradient. The superior part of the corpus callosum is not involved, but only the inner rim of the corpus callosum is involved. If at all it gets involved, that's what you want to see in VWM versus MLD. Those are the 2 close differentials. I think that's it from my side in terms of summarizing. Any specific questions, we'll be glad to answer. Dr. Shefali ma'am, can you give in your inputs, please?
Actually, radiology plays the mainstay for deciding leukodystrophies, but obviously clinical things will correlate, as already Puneet and Sakshi have said. I think there are 2 more questions, Dr. Atin.
So radiological differentiation between mitochondrial complex deficiencies and biotin thymine responsible basal ganglia disease. So mitochondrial complex deficiencies, we all know, are a large group of disorders. They may have varied areas of involvement. Basal ganglia is just one area which typically get involved in mitochondrial disorders, in specific disorders, but otherwise a combination of basal ganglia abnormality with brainstem abnormality or early involvement of cerebellar abnormality makes us think that we are thinking in terms of a mitochondrial disorder. The other pattern in mitochondrial is purely white matter abnormality. If you have white matter specific mitochondrial disorders, pointer in that direction is usually cystic changes which occurs, especially with the involvement of corpus callosum also. So if you have cyst formation in the corpus callosum, extensive involvement, and cyst formation in the white matter, that's a pointer towards mitochondrial disorders. The biotin thymine responsive basal ganglia disease is usually limited to the basal ganglia. Otherwise, if it is a basal ganglia predominant mitochondrial disorder versus this there are not much to differentiate, except there will be much more patchy areas of involvement, typically in a mitochondrial disorder. Biotin-thiamine responsive has a usually more diffuse basal ganglia abnormality. That's what I could think of with my experience in this. And what else? Any particular areas involved in particular leukodystrophies? I think it's all based on the underlying abnormality. And I think genetic defect, I won't go much into detail in that probably. I think rest I've predominantly answered. So cavum septum pellucidum, yeah, so that's commonly seen in Alexander disease. I've highlighted that, and the previous ones I've already answered in the chat box itself.
Thank you, Atin sir, for simplifying the imaging features in vanishing white matter disease, Canavan's disease, Alexander disease, and MLC. I always remember while interpreting the imaging features of a child with suspected leukodystrophy, sir used to say that you need to have a stepwise approach in the neuroradiology discussion when we were residents. So he used to say first you have to look at whether the patient has a leukodystrophy, then whether it is a hypomyelination or a dysmyelination. And the step 2 is whether the white matter abnormalities, what is the distribution, whether it is a confluent white matter hyperintensity or it's a multifocal involvement, and whether it is symmetric or asymmetric. And step 3 is what is the spatial distribution of the white matter abnormalities, whether which kind of lobar involvement, whether the callosal involvement is there, whether it's a central predominant or is the early subcortical U fiber involvement. And the step 4 is whether there are any special MRI characteristics, formation of cyst, whether there is any calcification, or whether there is any associated megalencephaly, any bleeds, contrast enhancement, or involvement of spinal cord changes, and MRS findings as well. And step 5 is always to exclude the mimics and the acquired causes. So I think this the stepwise approach will always help us to pattern fit and recognize the imaging findings in leukodystrophies. And I think there are no more questions in the.
Sangeeta,
yes.
Sangeeta, I just wanted to obviously that paper Puneet has shown. Just wanted to say that always the mainstay is stepwise pattern recognition. But out of the patients which we had seen, we found the megalencephalic leukoencephalopathy was 21, and then it was followed by MLD in 12, then Pelizaeus Merzbacher in 10, and X-linked adenoleukodystrophy in 8, Krabbe's in 5. And rest for all 2, 3, 2, 3, and all. So that means that is the commonest ones which come to a tertiary care center like ours. So that was generally the spectrum what we had seen.
Sure,
mostly. Yeah.
So there was one more question in the chat box, sir. How to differentiate CMV cystic leukoencephalopathy versus Aicardi-Goutier syndrome?
Yeah, so both of them are very close. I think not just radiological mimickers, but even clinically, they are pretty common mimickers of each other. So both of them, especially CMV, actually typically has usually associated microcephaly. There is a cyst formation typically seen in the temporal poles. And even in AGS, you have cyst formation in the temporal poles. AGS also has usually associated temporal gray matter abnormality also, whereas the CMV, if you see a gray matter abnormality, it's usually not just limited to the temporal region, it's more diffuse. Either there will be polymicrogyria or there will be a Lisencephaly type of a pattern associated with CMV. Both of them will have calcifications. It's been described that the calcifications in AGS are more chunky, usually not limited, but usually seen in the basal ganglia, more chunky calcifications. Whereas in the CMV, the calcifications are finer, stippled, more in the periventricular white matter. These are all soft markers to differentiate. Sometimes we end up not able to differentiate, and you need to take the help of either antibodies or do a testing to rule that out. But yes, both of them are close mimickers actually.
So in children with vanishing white matter, does MRS offer any extra benefit? Do you see a glycine peak or a prominent myoinositol peak, sir?
Sorry, I missed that question earlier. Yeah, but in our experience, we haven't seen, and in fact, as far as I know literature, usually in the melting white matter, we don't see much peaks. There is all reduced peaks which are seen in the vanishing white matter because of the melting away of the white matter. If you were trying to differentiate from cannabins, that we have a much strong predominant Na peak in those cases. So that's usually not too much of a differential on spectroscopy.
Sure, sir.
And you've summarized very well, Sangeeta, in terms of the flowchart. I did not actually cover the initial part of the flowchart here because in the last one and today we've both discussed only the dysmyelinating type of a leukodystrophies. We haven't touched the hypomyelinating.
Yes, sir.
For any leukodystrophy, your first thing is to know whether it is a leukodystrophy. For that, the most important thing is bilateral symmetrical. That's the important thing. We are talking about the general things, not to the exceptions. And after that, we try to decide hypomyelination, dysmyelination. Once it is hypomyelination, it goes to a totally different algorithm altogether. And we haven't covered that in the previous one and today's one. Maybe AOCN will have a separate topic on the hypomyelination. Since we've decided upon it being more of a demyelinating or a dysmyelinating pathology, so we were trying to depend upon the other findings, predominance in terms of periventricular to a subcortical or a frontal to a posterior with specific markers in terms of cystic changes, macrocephaly, contrast enhancement. That's what we were trying to discuss today and the last time. Thank you so much for
Sure,
summing
sir.
up, Dr. Sangeeta.
Sure, sir. Thank you so much, Dr. Sakshi and Dr. Puneet, for the excellent presentation. And sincere thanks to Professor Atin Kumar sir and Professor Shefali ma'am for moderating this academic session. If there are no more questions, we'll conclude this session. Thank you.
Thank you so much, Dr. Thank you so much, Dr. Kavita and Dr. Naita ma'am, for giving me this opportunity. Thank you.
Thank you so much for coming and enlightening us. Thank you very much.
Thank you.
Thank you, everybody.
Thank you. Thank you, everyone.